अरे वाह, ग्रेट।
वाणी
मदन,
देशपांडे
yes,
अकेडमी है वहाँ, बहुत बड़ी।
अच्छा
time
अच्छा।
to start.
okay. Yes, we will start.
Okay, start.
Good evening, all. Today, we are very lucky to have the collaboration of two FOXY committees, our Sexual Medicine Committee and MTP Committee of FOXY. And with the blessings of FOXY office bearers, President Rishikesh Pai sir, Secretary Dr. Madhuri Patel ma'am, Vice Presidents Dr. Gitendra Sharma sir, Asha Bakshi ma'am, our Chairperson Dr. Neeraj sir, and MTP Committee Chairperson Richa Sharma ma'am. And thank you all for coming and having this great event today. And by taking this opportunity, I would like to welcome all the guests of honor, and today's all the speakers, all the chairpersons, and all the delegates who have joined online from all over India. And I would like to welcome Dr. Neeraj sir for his welcome address. He is one of the dynamic chairpersons of FOXY, and he is our very dearest person in FOXY. And I welcome sir and request you to give welcome address.
Thank you, Madan.
Over to you, sir.
Yeah, thank you. So, good evening and welcome to today's webinar of sexual and reproductive health, which we are doing jointly with the MTP committee. So, 1 minute. Madhur madam is there? Hello.
थैंक यू।
मैं अभी 2 मिनट में आपको एक विशेष बात करूंगा। So when I approach, because the collaboration with the different FOXY committee is very important, because we learn to know each other's area, and we learn how to cooperate with each other to do any webinar or any program. So when I approach Richa, what we are thinking, what we should do, because her is the MTP committee and my sexual medicine committee. So we thought, okay, let's do sexual and reproductive health, which will be a very good idea. So I welcome you all on today's webinar. Friends, you know how important this sexual and reproductive health is for our women. Without giving stress to the reproductive and sexual health, we can't progress. Scenario of this reproductive and sexual health is not that much up to the mark. As far as our India is concerned, there are so many areas need to be covered, like concern with the maternal death, access to the abortion, access to the contraception. Most important about is the adolescent population. We have to recognize the adolescent sexuality. We have to remove the stigma and discrimination against women, against girls, and against the LGBT people about their right. So Swami Vivekananda told that it is impossible to think of welfare of the world unless the condition of the woman is improved. So we all understand how important this topic is, but it is not that, it is what I say, it is a somewhat neglected part when it comes to the practicality. So we from the Sexual Medicine Committee and Dr. Richa from the MPP Committee is trying very hard, and we are working with the patient to change the scenario. So I hope, and this is December, and this is our last month as far as for me for Sexual Medicine Committee, and Apurva will be taking over from the next month. So I am hopeful and very positive that he will continue the good work about the sexual medicine. So with that note, I welcome all of you, and I hope today's session will give you so many points to carry home and to make them implement in your day-to-day practice. So thank you. Over to you, Madan and Sama.
Yes. Shama, over to you.
Yes. Once again, welcome you all. I'm Dr. Shama Sultana. I would like to welcome Dr. Richa Sharma ma'am, MTP Committee Chairperson 2021-2024, to address today's session. Welcome, ma'am.
Thank you, Dr. Sharma. Very good evening and warm welcome, everybody.
So as Dr. Neeraj Jadhav has said, today's webinar is the joint venture of Sexual Medicine Committee and MTP Committee FOXY. And I thank Dr. Neeraj Jadhav. Basically, today's webinar is his brainchild. And I thank and I convey my regards to all the respected seniors, chief guest today, respected Dr. Pankaj Desai sir and Dr. Madhuri Patel madam. My regards to Dr. Jitendra Sharma sir and Dr. Rajendra Pardesi sir. Thank you so much. And today's webinar, basically, we are going to discuss very simple topic, very important, but they are very less talked about topics. And then we have case-based discussion on MTP legalities. And we have eminent faculties today, chairperson and speakers. They are very learned, and we are looking forward to hear from them. And I invite all the faculty, all the delegates, and all the guests for today's webinar. And I appreciate the sincere efforts of our coordinators, Dr. Madan, Dr. Shama, and Dr. Kiran Chandna for this webinar. And once again, I welcome everybody. And I hand over to you, Dr. Shama, for the further proceedings.
Yes, ma'am. Thank you, ma'am. Dr. Madan, sir, please welcome our chief guests.
Yes, thank you. Actually, we are honored to have great eminent persons as chief guest for today's webinar. That is Dr. Pankaj Desai sir. Everyone knows Pankaj sir. Actually, he doesn't need any introduction. He is the senior most person in FOXY, and he is an excellent orator. And he is working at Baroda. He was Dean of Students Medical College Baroda, and he was ex-HOD at SSG Medical College Baroda, and he was the past president of FOXY. And he is the excellent orator, and he is the dearest person in FOXY, most respected sir. And I welcome you, sir, and I request you to your words of blessing. Over to you, sir.
Thank you, Madan. Honorable Chairperson of the Sexual Medicine Committee, Dr. Neeraj, incoming Chairman, Dr. Apurva, coordinator of this program, Dr. Madan, Dr. Richa Sharma, the incoming, I think she is incoming or she is already in the post.
No, she is already there, sir.
So the current chairman of MTP committee of FOXY, a very old committee, actually one of the oldest committees of FOXY. First 5 committees were made. One of them was MTP committee, and for her information, I will tell you, I have just today launched uploaded a video on MTP in medical disorders in pregnancy. It has already been seen by so many people. May interest you. I have my YouTube channel, which has been, with God's grace, has been seen by more than 60,000 people. FOXY's strength is 30,000, and more than 60,000 people have seen this channel. And this is the latest uploaded today itself, of interest to Dr. Richa Sharma. Dr. Rajurkar, a friend of 30 years now, Dr. Deshpande, Dr. Seshadri ma'am, once again known to me for 20 plus years, Dr. Shama, whom I am seeing for the first time, unluckily, she must have seen me, but somehow when on the podium, you tend to get confused. And all of you who are here, thank you very much for inviting me and pulling me out of my dinner table, because 5:45 is my dinner time. But then anything for Neeraj, no problem. I always, Neeraj knows it. It is my habit that I don't give a, I am the only one who is officially allowed to speak away from the topic. Though many people speak even away from the topic, that is more a routine I have seen in academic topic lectures. Hardly anyone speaks on the topic, but I am officially allowed, and therefore I am going to tell you a story. I love to tell stories. I am not a grandfather, but of a grandfather's age, and so I love to tell stories. In Gujarati, it is said, Varta re Varta. And today, the title of the story is A Child's Thank You. Medical college hospitals have some very interesting routines. One of them is a grand round. Its structure and name may vary from one medical college to the other. And in the OBGYN department where I work, it was on the day of me and Neeraj studied there. It was on the day of our minor OT. The chief of the unit would take the round with all junior consultants and postgraduate students. It was a spectacle of sort. Spectacular is a Spanish word. I'm learning Spanish for last 3 years and about to complete a diploma. Spectacular is a word where similar scenes comes from Spanish. It was a spectacle. The chief, the so-called big doctor, walking by cot, surrounded by his entourage of his subordinates, his nursing staff, and everybody. One fine morning, in one such grand round, the chief stopped by a patient who had choriocarcinoma. Thankfully, we all know that choriocarcinoma is very responsive to treatment. The subject in question was being administered chemotherapy, while the chief was being briefed about the medical details of the patient's condition by his juniors. An intriguing thing happened, fascinating. The small child of the patient in question, must be about 3 to 4 years old, climbed up her mother's cot and started touching the chief's apron with its dirty hands. The chief looked at the child with loving eyes, patted the cheek, both communicated with each other with no words spoken. The assistants, however, were not happy. How could this dirty, shabbily dressed kid touch and soil the apron of their boss? It is said in Gujarati, and Neeraj must be knowing it, that cha karta pyala garam means the kettle is always warmer than the tea it holds. After the round was over, 2 assistants walked up to the mother and instructed her to ensure that this is not repeated. All seemed to have been forgotten till another grand round exactly a week after. The grand round that followed saw the same spectacle. The visit of the chief, the mother with an intravenous line running, and the child climbing up the mother's cot and reaching out to the chief, soiling his spotless apron. The chief, same, as kind-hearted as ever, gently patted the cheek of the child lovingly, smiled at the parents, which included the patient as well, reassuringly, and moved on. But this time, he didn't just leave. As soon as he reached the stairs, from the edge of his eyes, he watched his juniors making an angry rush to the patient's room. He quickly turned around and called all of them, "Come here," including his consultants. What followed was something very tender. The hospital, being a government public hospital, could not provide costly cancer chemotherapy free of cost. The patient in question was in no position to buy these drugs from her resources, as she was financially challenged. Chemotherapy, choriocarcinoma, as we all know, is very much amenable to chemotherapy, and its cure rate is near 100%. The chief seemed to have sensed this about the difficulties which the patient and her family faced. As he had done with many of his patients in the past, not necessarily of choriocarcinoma, but any financially challenged, he anonymously arranged for the costly drugs through his personal pocket. He had clearly instructed the chief resident, to whom he had told to arrange, through whom that chemotherapy was to be made available, not to reveal this to anybody. However, it seems in his exuberance, the chief resident had told the patient from where that treatment money had come. Just digest the whole thing. Apparently, The husband and the wife were thankful and had discussed their relief amongst each other in presence of that small child. Their child was sensitive enough to sense that it was that big doctor who had done something for its mother, which brought a smile and a peace to her parents. The happiness of the parents was sensed by the child. Children are very sensitive. They say that if the parents are well adjusted, the children turn out to be wonderful human beings. And they also have a wonderful subsequent married life. You may not teach your children. You just behave in a particular way and your children learn. We all know this. This is how we have learned. This is how my children have learned. The happiness of the parents was sensed by the child. And the brilliant chief had picked this up. The chief told his assistants and students, when the child is trying to reach me and make some physical contact with me, all that is doing is telling me a thank you. It doesn't have words. It is not scholarly enough like you people to speak it out. But it has a sensitive heart. The child was making attempts to reach this man who gave happiness to its parents. That was enough for the child. Little did it know what the happiness was. It knew no language but the language of touch. So it was trying to touch the chief. Her child is simply telling all of us through me, thank you. Just listen to these unspoken words of the child. Just feel the words in touch of the child. Don't stop it. It is just saying, thank you. Thank you very much, Neeraj. Thank you, everybody, for your patient hearing. May God bless you all. Thank you.
Thank you, sir.
Thank you, Pankaj sir, for your kind words and blessings. Thank you, sir. I welcome our next guest of, chief guest, Dr. Madhuri Patel ma'am. Everyone knows actually there is no need of introduction. She is currently the Secretary General of Foxy, dearest person in the Foxy. I welcome ma'am, and we need your blessing, ma'am. Over to you.
Thank you, Madan. Can you hear me?
Yes, madam.
Yes.
Yeah. So respected Dr. Rishikesh Pai, our President Foxy, most dynamic and visionary. Then our Vice President, Dr. Asha Bakshi, Dr. Gitendra Sharma, and of course, Dr. Neeraj and Dr. Richa, who are doing excellent work in their committee as a chairperson, and they are involving all their members. So they are doing fantastic work. So I'm congratulating them. And of course, our chief guest, Dr. Pankaj Desai. Then we have Dr. Pardesi as our, chief guest of honor, along with Dr. Gitendra Sharma, Dr. Madan, and Dr. Shama, our master of ceremony. Then Dr. Kishore Rajurkar, Dr. Vijaya Lakshmi, very good friend of mine, Dr. Savana, Dr. Vani Puri, Dr. Apurva, Dr. Sanjay Deshpande, Dr. Kiran, Dr. Renu, Dr. Pratima, Dr. Alka, Dr. Mausmi, Dr. Suyoga, and Dr. Kanchan, and all my dear friends. A very, very good evening to all of you. At the outset, I would like to thank Neeraj and Risha and all of you for giving me this opportunity. Let me tell you, because of Foxy, I know all of you, and I have all close contact with my all dear friends and all the 41,000 plus they are all my dear friends, and I'm proud of it. Today, I'm in Nadiad because there is a gender equality run is going on all over the country, and I started with Surat, and it was a fantastic, run with CME. Then I went to Bharuch. I said, I'm on the way to, places, so I can, go to Bharuch. I went to Bharuch. Then I came to Baroda. Then I came to Anand. Then now I'm in Nadia, and I'm going to Ahmedabad because Ahmedabad is again tomorrow is a run with CME. I'm so overwhelmed and I'm honored that all these people they respect each other so much, and so me also. And I'm really happy to learn from them how as an obstetrician, we are not only obstetrician and gynecology, but we all have a human touch. As it has been mentioned by our chief guest, Dr. Pankaj Desai, that how the human touch is there. Even the big boss can shout at you, but at the same time, how the soft they are with the patient and the case. So it is very inspiring, and I'm really, the topic of today's are very, very, very need of the hour. That is teenage pregnancy, sex in pregnancy, sex therapy, and panel POXO Act legality simplified. So these topics, our speakers, our chairperson, moderators, and panelists are excellent, and they are going to enlighten us on this topic, which is going to help us in day-to-day practice. So many times we face so many difficulties, but by giving this knowledge, updating us, it really solves many problems. So I congratulate Dr. Neeraj, Dr. Richa, and Dr. Rishikesh and Asha, and Dr. Gitendra for the most apt webinar, and I wish them best luck. Thank you once again for giving me this opportunity.
Thank you, Madhuri Madam, for joining from the traveling. So,
Always for you.
Thank you, Madhuri ma'am. Thank you for your blessings. You are always with Foxy. Thank you, ma'am.
Yes, thank you, ma'am.
Pardeshi
Yes.
sir is busy in some function, and Gitendra is traveling, so they are not joining. So you can proceed further. Invite
Thank
the
you,
chairperson.
Madhuri ma'am. Thank you for joining.
Okay.
Thank you, all of you.
Okay. We will start with the session directly. We will start the first session. I would like to invite the chairperson for first session, Dr. Kishore Rajurkar sir, Dr. Vijayalakshmi madam, and Dr. Savana ma'am. Shama?
Yes. Dr. Kishore Rajurkar, sir,
Yes.
please
Ah.
welcome Deshpande.
Okay.
Okay, he is a senior consultant, gynecologist and perinatologist, and ex-HOD, OBGY, and minimal access surgery at SGM Hospital, New Delhi. Welcome, sir.
Thank you.
Yeah. Second chairperson is Dr. Vijayalakshmi Shishadri. She is a senior consultant, OBGY at Sundaram Medical Foundation, Chennai. And third is the Savana ma'am. Everyone knows she is a very well-known cosmetic gynecologist at Imphal. Welcome all the chairpersons.
Thank
and
you.
I request Kishore Rajurkar sir to introduce our speaker. Welcome, sir.
First of all, I want to thank Foxy and Dr. Neeraj for allowing me to be a part of this wonderful webinar or conference. And actually, the sex leads, sex is required for MTP. So it's a combination of, sexual medicine plus MTP committee. So it's a, both aspects will be dealt with. And for the sexual aspect part, I'm going to introduce Dr. Sanjay Deshpande, and he is the past chairperson of CSEPI since 2017, and also the assistant secretary of AOFS, member of CWC IMA headquarters 2021 and 22, vice president IMA Maharashtra 2017 and 2018, honorary secretary Indian Andropause Society, and also he's the past president of Indian Medical Association Nagpur, and the recipient of the Golden Lamp Award. And I welcome him and to speak on his topic, Dr. Sanjay Deshpande, sir.
So thank you, Dr. Rajurkar, for my introduction. Thank you, Dr. Neeraj. Thank you, Dr. Apurva, and thank you, Dr. Madan, for inviting me here. I'm sorry because I asked you the permission to present my topic earlier because I have to catch my train at 7 o'clock. And I'm just sitting in the taxi just in front of the platform number 18 at Mumbai CSTM. So if there is any inconvenience, kindly pardon me. So I will be means rushing through this, but I will have to share my screen. So kindly make me able to share the screen.
Co-host बना दीजिए.
Yes, sir. Now you can.
Okay. Now I will be directly going through this slide because the topic which has been assigned to me is sex therapy. And everyone knows it, that it's a very huge topic. And before that, we have to see what is the psychodynamics, what is the psychology, what is the organic causes. But there is one common saying that even if there is any organic cause, the psychology is always involved. So you cannot separate psychology from the organic cause as well as from the sexual functioning of a human being, maybe a man or a woman. Now, mostly we usually discuss more sex problems in regards to male sexual health rather than female sexual health. But psychology is even more strong base of a woman's sexuality. So I'm happy that I am being invited at the forum of Foxy, and everybody of you are interested in knowing the things and learning it. And you are we always say that there is only one sexual sexual medicine science or a discipline in medical science, and that is obst and gynecology, because you deal with the sex and the aftermath of sex also. So what Dr. Razurkar said, that I thought I am correct that I asked my talk to be earlier because sex is needed for MTP. So that is also a good coincidence here. So we directly come to the psychosomatic circle of sex.
Sir, I just please make it full screen. I mean,
it's a full screen, I suppose. No, okay.
I don't know.
Okay, yeah. Now it's full screen. Okay.
Yes. Now it's fine. Thank
you. Now, why we want to understand this psychosomatic circle of sex, as I have told, that it is always our psychology and circumstances which are important, because we are dealing with the sex therapy, and why sex therapy is needed. The importance of it lies in this diagram. As you see, there are all the components: cognition, awareness of responses, peripheral as well as genital responses, and the limbic system and spinal cord, spinal center. So everything is involved here. Even if it is somatic, sometimes it is somatic through spinal centers and through peripheral arousal or genital responses. But awareness of response and cognition, what are the attitudes, fears, and expectation of a person, that is very important, either in dealing with sexuality as well as dealing with the sexual dysfunction also. Now, what I'm not going to in details about the drugs and all things, but I will be go to the psychological basis of sex. Basically, that is very important. Why we want to know about the psychology of sex. Now, origin of psychological problems, the first and foremost is comfort. Now, comfort is not only physical comfort, but it is psychological comfort, social comfort, everything what is comfortable for a man and woman about each other also. Then only a normal or good sex can take place. Even security. Now, security is not only physical, but security, interpersonal security, the faith in the relationship, everything comes in security. That is also important for a good sexual relationship. Knowledge and personal values. What I see about regarding sex, what my previous experiences regarding sex, what are my expectations regarding sex, these all things play, and they have a deep impact on our sexual beliefs, attitudes, and lastly, practices. Then interaction between factors in current and past situation. In past, I was not able to do that. In past, I was troubled. In past, I was exploited. In past, I was abused. These all circumstances and past experiences, they also have a deep impact on sexual behavior as well as attitude and feelings of a human behavior. And lastly, interaction of interpersonal and intrapersonal. There is a spelling mistake here. Now, these beliefs are of a person. In sexual relationship or in marital relationship, there are two persons involved. So it is an interaction of two intrapersonal sets of problems. And that's why it is many times difficult. No attitudes, feelings, ability to communicate, how the manage is angered, and how the intimacy level of the couple is. That is also very much to be understood when we are dealing with sex therapy or dealing with the dysfunction of sexual problem of a man or a woman. Now, interpersonal problems means difficulties in adjusting each other, as I already told you, and it is interplay of two sets of intrapersonal problems. Now, there are many misunderstandings and ignorances also. Like in sex, people ask how many times I have to perform during my first night. Many patients comes to me, Dr. Saab, my friend does sex 2 times in one night. So what I should do? I jokingly tell him, you go and tell your friend that you are performing 3 times. So then he asks me, what will happen after that? I think nothing will happen. Only your friend will come to me complaining that you are doing it 3 times and he is able to do it only 2 times. So sex is many times taken as a competition, as a comparison. And that is not important. But people have that habit. Even people have some feelings that they see the pornography and all things, and they feel that simultaneous orgasms simultaneous orgasm of a man and woman should take place at the same time. It may not happen most of the time, but that is the attitude or myth and misconception in their mind. Clitoral versus vaginal orgasm also is very important. Erection without touching. Many people say, even if we prescribe them sildenafil, tadalafil, they feel that they should get automatic erections and then they will proceed for sex. So these are small things, simple things, but we have to deal with these things. We have to tell them very simply and categorically. Then only the sex therapy and other treatment, they work. Then semen loss is loss of vitality. All the misconceptions regarding masturbation and all, they are the root cause of sexual problems of most of the men. Those unsuitable circumstances also plays an important role. In less affluent society, people have no privacy. Now, whatever I will be telling you in sex therapy and sunset focus, that is not possible in our country in 99% of the people. Why I am saying 99% of the people is even in rich and affluent society, the couples, they sleep with their children. Even if there is a large king bed, at one side, the husband will sleep, at another side, the wife will sleep, and between them, 2 or 3 or 1, whatever may be the number of children, they will sleep. So they don't have privacy. Because we feel that children are more important for us. They should sleep with us. And this sleeping pattern in even very, very high society also is a situation which we have to deal with. Am I audible?
Yes, sir. Yes, sir.
Yes, yes. And in affluent societies, always pressure of work. Nowadays, you know, a man is busy with his laptop, a woman is also busy with her laptop. Though they don't, even if they are sitting in the same room, sleeping in the same bedroom, but they are busy with their work, even outside their offices also. And now work from offices has made the hell of the situation. So unsuitable circumstances are, these situations are in every community, rich as well as poor. Then child sexual abuse, guilt, sufferer role, they also play a very important role in shaping up sexuality of a human being. Sexual arousal, it is always say that a best sex will be possible only when a person let go everything. A man or a woman, he or she has to let go every other things. Should not remember any other thing, and only that's why Osho has said that sex is like meditation. So you have to forget everything and concentrate on sexual stimuli which you are receiving. Then only a person will be able to have a good sexual pleasure. But that is not possible because of the so much social control on us regarding sexuality. And of course, if the sex is painful, then also sometimes it is possible that a person may not be interested in sex or may be afraid of sex, whatever it may be. You may, all of you know is better than me about dyspareunia and vaginismus and all. Many times it's just the thought of fear, pain also make the contractions of vaginal muscles. Bad feelings about own self, low self-esteem, uncomfortable about body shapes and looks. The most common problem in our society, patients coming to us, they are very much depressed because of the small size of penis. Now, 4 inch of erect penis is sufficient for a sexual intercourse. We have to tell them, but still they are not ready to accept it. They feel that there must be some treatment available which will make them their penises 6 or 7 inches long in erect state. That's not possible. So there are many bad feelings about own also that is causing the disturbances in sexuality. Bad feelings about partner, marital conflicts, hostility, all also things take place. No or wrong communication. Many times communication is not at all present in couples regarding sex, what one like and what one does not like. Now it is always say that whatever is not liked should be taken care more than whatever is liked. Because by doing anything which a partner doesn't like makes him more irritated, makes her more irritated. So that communication should be there. There are anxiety, anger, mood, awareness. There are a lot of emotional issues also. Now in sex therapy, what we do, I'm just now coming directly to the point. These are the all psychological here and now problems. Means these are problems which can be taken care very easily. That by asking them to have a privacy, by asking them to have their sleeping pattern different, by asking them that they should sleep separately, ask their children to sleep separate bedrooms. These simple factors also can make the person more focused on sexual feelings. So by doing small changes, which are always called as here and now causes, the causes which are present there. But what sex therapy does is there and then causes. Even intra means conflicts between partners, conflicts, psychological conflicts, this Oedipal complex, Electra complex, these psychological problems, they will emerge when the sex therapy is continued. So sex therapy is not that we will advise them to do certain things and they will be all right. Many times they will come with some resistances. Actually, in sex therapy or in counseling, the most important process of counseling is same everywhere. But we have to deal with the resistances. If suppose I ask some couple to do some exercise, some sensate focus exercise, and if they don't do it, either a man or a woman did not want to do it, then I have to understand what is the resistance, what was the reason of not doing it. So knowing these things is very important in sex therapy. So I am directly going to the sex therapy. Even sexual ignorance and unconscious avoidance of good sex. These are also two important things which come. Now, the common psychological causes of sexual dysfunctions, basically the unconscious. Unconsciously, patient feels that sex is bad because of the childhood experiences, because of the relationship of mother and father, both. They may feel that the sex is bad thing. Or sometimes it is said that is Electra complex or many other things, that I may be punished if I am sexually aroused. If this fear is from the childhood, the person cannot become comfortable psychologically. And suddenly when he has some psychological problems, he loses the interest in sex or erection, or in females, she may suffer from pain or discomfort. So this repression resistance, what happens if there are some uncomfortable psychological feelings with some situation, and that is being repressed by the patient or by the person, but that will re-emerge when there is a sexual experience. So these people, they are absolutely normal in their whole life or whole day, you can say. But only when there is a chance of sexual interaction, there these factors emerge and they become irritable, or what you can say, uncomfortable, and they can't perform. Even infantile sexuality also plays a long role. Sexual pleasure and conflict. For the whole year of 22, 25 years till marriage, the person is preached and teach that sex is not good, bad. So there is a conflict between pleasure, whether pleasure is good or not, whether sexual pleasure is good or not. That conflict also can create disturbances in the mind. Child rearing and sexual conflict, touching the genitals. Parents beat the child if he or she touches the genitals. So touching the own genital, if it is considered as bad, how can she or he will touch another person's genitals? Constrictive upbringing, very religious upbringing. And then these are the interpersonal problems, dyadic problems, that partner rejection. If I don't perform sexually, my partner will reject me. I have to please her. I have to please him. These compulsions, this performance pressure also can play a very important role in sexual functioning of a human being. Marital discord and causes. Wife is very much dependent on husband. Husband is very much dependent on wife. Lack of trust. Husband has breached the trust for some another reason, or wife has done something which the husband did not like. So even trust deficit also can create sexual problems. Power struggle. It is said that marriage is not so simple. It's not always love. It's all business. So there is a power struggle between husband and wife. In India, it is even more complicated because there is power struggle in in-laws and wife and in-laws and husbands also. So it is not only relation between husband and wife, but it relation between in-laws and husband in these problems. Sexual sabotage and failure of communication and contractual disappointments. If husband says that I will bring you some necklace or something like that, and if he doesn't bring that, then wife is not happy. She'll always tell, only I will do sex if you bring this and this. Or husband also will nag the wife that if you do this, then I will do sex with you. So these are the power struggles or politics in sex, we can say. Now I will directly go to the sex therapy. Now what is sex therapy? Sex therapy is a strategy for improvement of sexual function and treatment of sexual dysfunction. Now this includes all the dysfunctions, but now let me tell what we do in our sexology clinic. Because of the advent of various drugs in treatment of erectile dysfunction, premature ejaculation, because most of our patients are males, I can tell you very frankly. And because of that, their performance pressures has to be desensitized. So sex therapy is nothing but desensitizing either the performance pressure or the inhibition, mostly in case of women, or the fear like dyspareunia and all, vaginismus. There is a constant fear and a patient cannot help herself. So how to desensitize the fear, how to desensitize the pressure, that is more important. So what is sex therapy? To start with, what we do is that we ask them to do only non-genital touching. Touch is very important in sex therapy, or touch is important in human life. But we Indians were somewhat restrictive. We are not that open to touch. I always say that whenever we meet each other, we say namaste. But even Western world, whenever they meet, they will shake hands with each other. So they are open to touch. And touch is a very good communication also. So in this sex therapy, what we do is start the non-genital touching. The husband and wife or the partners are assigned some non-genital touching with each other, barring the genital and breast touching. And sex or sexual intercourse is prohibited in this. Then in subsequent stages, genital and breast touching is also allowed, but still there is a prohibition of sexual intercourse. Now what happens in these two? We assign that first one has to be a toucher, one who touches, and another has to be a touchy. So if a husband starts touching, then wife will only relax and her job will be to tell whatever is pleasing to her and whatever is irritating or non-pleasant to her, so that the husband knows that what part of her body is more sensual, what she likes more at certain part of her body. And same thing is about a man. So first touch, only wife will touch, husband will be relaxed. Then husband will touch, wife will be relaxed. Then genital and breast touching each other also will. So it is different from foreplay. People say that this is foreplay. No, it is different from foreplay. Then mutual touching. No, they will touch each other also in between. First is that completely one person will be touched by another. Here they can touch each other simultaneously also. Then if there are proper erections, or if there is no pain or something like that, depending on the sexual dysfunction, then we ask them to just insert the penis inside the vagina, so that is called as vaginal contentment. Most of the time we ask them to have female on top position. Now female on top position is a very therapeutic position where a husband, means a male sexual dysfunction also can be treated properly, as well as female sexual dysfunction. Why female sexual dysfunction? Because female has the complete control on the sexual intercourse. And that's why female on top position is considered as a therapeutic procedure. And last is sensual intercourse. It is not called as sexual intercourse. So sensuality has to be ensured by touching each other, by exploring non-genital arousals also, because there is a body is consisting of large area of erogenous zone that has to be explored. People never explore that. They only feel that the penis has to be inserted inside the vagina, and only after deposition of semen they are happy. So that aspect has to be taken. They have to be told that they should not be goal oriented. A goal is not even during non-genital touching. If a man gets erection, we ask them not to have erection. So erection has to be subsided, and then only they should start touching. So focus is not on erection. Focus is not on insertion. Focus is on experience. What the touch means to a man as well as a woman. So I'm not going into the details of it, but only I will share something to you. Because this will require at least 3-4 hours. Now, there are 3 dimensions of touch: temperature, pressure, and texture. I always ask my patients, when you touch your wife or your female partner, whether her body is ठंडा है या गर्म है, soft है या hard है ना, texture, how her skin is. So these 3 things we never explore. If we start our couples to do these 3 things, they will experience the pleasure of touch more, thereby not having the focus on erections alone. So that is more important. That has to be taken care of more. So the purpose is to provide a structured approach which allows the couple to rebuild physical intimacy and gradually rebuild their sexual relationship. So both things can work. So these are the graded hierarchical exercises which we give to these couples, and then they are asked to come after 15 days, 20 days. Only thing is that we cannot tell them that they have to complete this task within these days. Because sometimes what happens, some couples will take 2, 3, 4 weeks. Some couple may take 2 to 3 months also. It depending on how deep is the psychological issue. So those who are having here and now problems can be cured very, very easily and very, very quickly. But those who are having very deep-rooted psychological causes will not be treated so early. So sex therapy is a very time-consuming job. But with the advent of all these drugs and all, erectile dysfunction has become quite, what you can say, effective in treatment if we, in combination of sexual medicine and sex therapy, if we treat our patients, they will give excellent results. We have to even tell that sex is not danger or fear. Sex is a calmness or sex. That's why in my clinic, I have my mission statement or my catchline is relearning the sexual pleasure. People feel that they have now doing sex till now and they were successful. But what happens after failure in sex? Because of certain failures, once, twice, thrice, or
Excuse me, sir.
pardon?
Only 2 minutes remaining, sir.
Okay. So my sincere advice to everybody is that we have to understand the circumstances and psychology of a person as a whole. And if possible, in India it is very less, but if possible, the partner also should be included in the treatment so that he or she also knows what are the causes of the patient's sexual dysfunction. And then if through couple therapy, if we treat them, at least they will know each other better. Their marital relationship also will increase and their sexual functioning will also improve. So with this, I thank you all. I was fast because we have to complete all this in 20 minutes. It's difficult, but I understand there are time limitations. But I think next time, if possible, Neeraj or Apurva, keep a complete session on sex therapy so that we can discuss it thread and then. Thank you very much.
Sure. Thank you, sir. Thanks for the informative session. I would like to ask Dr. Kishore Rajukar, sir, to give his expert comments.
First of all, I thank Dr. Sanjay Deshpande for a wonderful presentation. I just have a few comments to make. That the gist of this therapy, the gist of the therapy basically is psychological treatment, and it is not the drugs.
Yeah.
Which is not the primary thing, and it is the you have very nicely presented that thing, and it is the many times you have to fight with people of Khandani Shafa Khana and all that, because most of the people, they don't go to sexologists. I mean, they don't go to the gynecologists. They will go to these people. So that part is also there. Another thing is that the sex, I mean, sexual sex or masturbation, all that is a basic instinct. And it starts from the infancy. I mean, you must see, I mean, even the infants will touch their genitals. And so it starts from there. The pleasure starts from there. And therefore, it should not be the sexual pleasure is a basic thing, and it has to be part of our whole life. And many times, actually, nowadays also we are having, they are not, they are living, without marriage, they are living together. So that, unka alag aspects hain. I mean, sexual problems ke alag aspects hain. And the teenage, pregnancy, all this. So therefore, beautifully presented. And thank you very much, Dr. Sanjay. एक तो आपने वहां बैठ के टैक्सी में बैठ के इतना बढ़िया प्रेजेंटेशन कर दिया, अगली बार और बढ़िया हो जाएगा. Thank you,
sir. Kindly permit me to leave the meeting.
Yes, sir. Yes, sir.
Sure.
Yes, sir.
Thank you.
Yes. Now our next topic, teenage pregnancy. For this, I would like to welcome Dr. Vijay Lakshmi Sheshadri ma'am to chair the session and thereby introduce our speaker, Dr. Vani Puri ma'am.
Thank you for this opportunity, Neeraj and Apurva and the entire team from Foxy. I'm very delighted to be here today and to chair this session, and I would be very happy to introduce Dr. Vani Puri, who is a consultant obstetrician gynecologist and is also North Zone Coordinator for the Sexual Medicine Committee. She's also the President of the Indian Medical Association, Ghaziabad, and also has been a secretary in the past and treasurer in the past. And she's also the member of Cultural Committee of the National IMA. We all know it is, although on one hand, we do have difficulties with the sexual orientation, sexual contacts, everything. And after this, I would say rather explosive talk by Dr. Deshpande. Now we are into a different problem where at the this age in teenage, where it is not being uncommon to have teenage pregnancies, though they all have awareness about contraception nowadays, they all have awareness about the problems, but still they end up into teenage pregnancies. And with the change of the social fabric and the social status, I think we are coming through this stage as well because of the a little bit of taking off of the inhibition on the teenage girls. And of course, the MTP Act, the POXO Act, there is so much of overlap in this age. And teenagers have already lots of issues regarding the hormonal overlay, and then the family responsibilities, which really counter whatever they want to do. And it's a big burden on the family members as well, because it is not so socially recognizable, especially in the Indian scenario. So let us hear Vani to talk on the teenage pregnancy, all about it, the problems physiologically, and also about the legal issues and the sexual and the MTP issues. Over to you, Vani.
Yeah, ma'am. Thank you, Vijayalakshmi ma'am, for the generous introduction. And respected and Sada Pranam to the chief guest, the chairpersons of the session and the chairpersons of the sexual committee, Dr. Neeraj Yadav sir and Dr. Richa ma'am, chairperson of MTP committee. So after a brainstorming session on sex therapy, let us dive into the topic, which is as a resultant of unsafe sexual behavior by the teens, the teenage pregnancy. So taking an overview, the teenage pregnancy is a burning societal issue that affects the people all over the world. The major effects are to the mother and the child born, particularly in the underdeveloped nations where the healthcare is not that advanced. According to the United Nations Children's Fund, UNICEF, teenage pregnancy is defined as a pregnancy in the girls from age 13 to 19 years. Nevertheless, the pregnancies in the ages 12 and less are also included in teenage pregnancies and also called adolescent pregnancies. Despite the minimum legal age of female marriage in India to 18 years, still 9% is the rate of pregnancy in India in 2023 between 15 to 19 years. The India has the largest adolescent population, so we need to really seriously think on that, counting to 253 million with around 11.8 million teenage pregnancies. So coming to the facts, according to the WHO 2019, the adolescent age 15 to 19 years in low middle income countries estimated to be 21 million pregnancies per year. And 50% of these pregnancies were unintended and unplanned. Out of these, 55% of unintended pregnancies, they end into abortions, and mostly the unsafe abortions. The low middle income countries' complications from pregnancy and childbirth are leading major cause of death among the girls between 15 to 19 years. Stillborn and newborn deaths are 50% higher in teenage mothers, and also the infant of the adolescent mothers are more likely to have a low birth rate. So if we see this figure, so disability accounts for around 4th in position for the adolescent girls. And the maternal mortality rate counts, the maternal condition counts for the second. It hits the list at second commonest cause for the mortality in the adolescent pregnant teens. So 16% of the women between the ages of 15 to 19 years are already having children in India. And state of Jharkhand is 28, where the maternal marriages are very common, and even below the legal age of 18, 35%. And followed by the 25% of the pregnancies in the West Bengal, and Bihar accounts for 25% of the teenage pregnancies. Over half of the women have anemia, and around 11% have shunted growth, and 47% have the low body mass index less than 18.5. So it doesn't only deals with the health, but also violates the human rights. It brings up around lot of problems in the human rights. The pregnant adolescent woman is forced to miss the school, denied her rights to education. She is forced to denied from the right of health because she is not allowed to use any sort of contraception, or there is no access and knowledge to the reproductive health. And teenagers are not physically and mentally prepared for the pregnancy or delivery. That increases the risk problem and even the life-threatening health effects. And early school leaving and health issues compromise their ability to make money. And these teenagers now go through the economic crisis also. So let's go through the teenage pregnancy. What are the causes? The lack of paternal care, the lack of formal and informal education, the lack of sexual education, insufficient communication and supervision by the parents, poverty, peer pressure, negative family interactions, single parent, substance abuse, family history of teenage pregnancy, forced and child marriage, and insufficient knowledge about contraception. These teenagers, they face a lot of challenges also. The challenges regarding the career and the source of income, challenges of substance abuse, because the unsafe sexual behavior and the substance abuse both go hand in hand. The maternal health problems like financial strains, societal stigmas, lack of support from her family and community. These young mothers also experience a lot of mental issues, including the stress, anxiety, sadness, and suicidal thoughts. And also the post-traumatic stress disorders also are very common. Now coming to the medical consequences. These teenage pregnancy, they experience lack of prenatal care because they don't know they are pregnant. Even if they know that they are pregnant, they don't know where to go. Preterm deliveries because of lack of prenatal care, PROM, obstructed labor because of the inadequate pelvises and they are not grown properly, fistula due to the obstructed labor, the operative interventions are more, anemia, pregnancy-induced hypertension, GDM, STIs and HIV, hemorrhage, infection, both the urinary tract infections, also the postpartum infections. It is seen that the medical termination of pregnancies is up to the tune of 9% versus 5%, which is seen in the adults. And most of these terminations are unsafe. And this all leads to the increased mortality in the teenage mothers. So preeclampsia and eclampsia are more because of the underdeveloped uterus, irregular menstrual cycles that might affect the desudilization, the deplacentation, and the spiral artery remodeling. So leads to preeclampsia. The girls, adolescents are more prone to infections because of the STIs also. There is a raised inflammatory markers leading to PROM. Higher iron requirements, faster growth, food fats, fast food intake, and loss of nutrition, they lead to anemia. Teenage sexual activities, unsafe sex, unsafe sexual behavior, lack of sex education, they are seen, and this makes the teens more vulnerable to STIs. The vertical transmission of these STIs can cause injury to the fetus, and additional elements contributing to the spread of disease include the drug abuse, the socioeconomic inequalities, and the false beliefs. Now coming to the neonatal effects. The neonatal effects are there is a preterm birth, intrauterine growth restriction, necrotizing enterocolitis, hyaline membrane disease, respiratory distress syndrome, bronchopulmonary dysplasia, retinopathy, neural tube defects because of the nutrition deficiency and loss of prenatal care in the teenagers, birth injuries, chorioamnionitis, and the stillbirth. Postpartum and long-term complications, there is a failure of lactation because there is no support, no social support, no parental support to these teenager mothers, and nutritional problems are there, psychosocial, psychological problems, strong association with the depression and anxiety is usually seen in the teenager motherhood. Repeat pregnancy is very much seen after 2 years. Long-term socioeconomic disadvantages and the health disparities are also there. And high rate of substance abuse is also seen even in the postpartum and long-term states. Behavioral problems and the physical abuse in the children born to the teenage parents are also seen. So we all know what are the components of teenage-friendly healthcare. We need to provide them a welcoming environment, ensure the services are easily accessible, and provide clarity and confidentiality, provide the care that in a respectful manner, and we should not judge them. We all know that. Provide accessible information, use an empowering approach, and we should also include the fathers, the male partners. Now, first, we have to reduce the risk of unintended adolescent pregnancy. In a very sensitive manner, we should explore the pregnancy intentions of the couples and the contraceptive beliefs. And we should encourage them to use a long-acting reversible methods. And check that the couple knows about the barrier methods or not, because this will provide them the protection from the sexually transmitted infections, and check the knowledge about the emergency contraception. So if the pregnancy has now occurred, now we have to provide a non-judgmental support and counseling to these mothers, and we have to screen them for the sexual abuse and exploitation, because these girls are very susceptible to the sexual abuse. Now, coming to the antenatal care, we have to recognize the teenagers. They have less knowledge of the anatomical structure, and they don't know what is going and what changes will there be in their body at different stages of pregnancy. We have to educate them about these changes. Access the nutritional adequacy and use the local protocols of antenatal care. We have to give them as usual. And we have to screen for STIs, because these are the age group which is very susceptible to different STIs, and we have to routinely screen for any alcohol abuse, substance abuse, any violence and mood disorders. We have to see whether they smoke, then we have to support them to stop smoking, and teach about the signs and symptoms of the preterm, because they are very susceptible to the preterm labor, and discuss about the contraceptive methods before delivery in hand, because we need to counsel them about the contraception, because they again get pregnant within 2 years. They encourage and facilitate the breastfeeding and include their partners also in the counseling. Now, then we have to make sure that after the postpartum, after they have given birth to their babies, they return to their school, the education is completed, the training and healthy lifestyle is also encouraged, and breastfeeding is encouraged, and nutritional adequacy is seen in the breastfeeding mothers also, and the smoking cessation is continued if they have not stopped prior. So these are the things which we can prevent the teenage pregnancy. Broad efforts like involvement of the school health cares and the education of the community has to be done. Inquire about the sensitivity about the pregnancy intentions. Then you have to encourage about the long-term reversible contraceptive methods. Check the knowledge about the barriers, and the check knowledge about the emergency contraception. So in conclusion, pregnancy in adolescent have a transformative impact on changing unhealthy behavior and relation in some teenage. But however, many teenage pregnancy are accompanied by adverse perinatal outcome and long-term social and educational consequences. We as a healthcare provider should support these families and offer a regular and reliable care in a non-judgmental way. And evidence supports that if we counsel them to use a long-acting reversible contraceptive methods to prevent the unwanted teenage pregnancy, it can reduce a rapid repeat pregnancy after delivery. Thank you very much. Let's all join hands and stop the teenage pregnancy. Thank you very much.
Thank you, Vani. That was a wonderful presentation, short and sweet and keeping to time. And we all know the problems exist in the ends, two extremes of age, and you have very well covered this teenage pregnancy. And
Thank you,
probably about the terminations and all, we will hear from Richa in the panel.
Yes, ma'am.
And you have done the positive, non-judgmental. I like that a lot, because it is very important that we give a non-judgmental support to these teenage pregnancies whenever we come across, especially in our country, because the social taboo is so high on this that they run away from these problems, don't recognize their issues, don't
Yes.
reach the doctors on time, and do not get attended in the way they need to. And
Correct.
therefore, your talk was very, very impressive. Thank you very much, Vani, and all the best
you.
for all your future endeavors. So,
Thank you, ma'am.
over to you, Shama.
Yes, thank you, ma'am, for your expert comments. Without any delay, we shall go to our next topic, sex and pregnancy. For this session, I would like to welcome Dr. Savannah Chungdam, ma'am, and thereby she can introduce our speaker, Dr. Apuba, sir.
Good evening. First of all, I would like to thank Neeraj, Dr. Neeraj, Apurva, and organizers in the Foxy for making me a part of this excellent webinar. Dr. Apurva Datta does not need any introduction, but just to introduce, he is the chairperson-elect Sexual Health and STI Committee, Foxy. Dr. Apurva.
Thank you so much.
Short and sweet introduction.
Thank you so much, Savannah ma'am, for always being there, for always your advice, and your sweet smile make everybody smile. So thank you so much. And thank you so much, Neeraj sir. Sir, you are the pillar of strength. आप मेरे शक्ति पुंज हो. I always admire and always get the energy by seeing the amount of work you are doing. So thank you so much. Being a MOC to have a promotion to the speaker in my own webinar. In between, I was thinking, na, yeah, I was feel like now the topic is stopped. Now I have to call the chairpersons for giving their comments. I am feeling like that. So thank you so much, sir. So without wasting the time, I would like to. Is it visible?
Yes, it is visible.
Yes, it's visible.
Yeah. So, my dear friends, after those wonderful talks, now I am going to talk about sex and sexuality in pregnancy. Now, many times when I am giving this lecture of sex and sexuality in pregnancy, then people are asking me, even gynec are asking me, why you are so fond of having sexual intercourse in the pregnancy and in the pregnant lady. So the reason being, previously it was the maternal improving the maternal mortality to now it's coming to respectful maternity. Previously it was it was about safe abortion. Now it's the respectful abortion. Similarly, the sex and sexuality is about the quality of a life of every human being, whether he's a male and a female, and to devoid a couple of having sexual pleasure and having that quality of life in pregnancy, it is not justifiable. And that's why I'm here with this this very controversial topic of sex and sexuality in the pregnancy. Now going to basic, women's sexual function is really a complex interplay between the physical, psychological, and emotional factor. To be a mother is a natural instinct. Both the pregnancy and sexuality are normal and normal phenomena of a woman's life. So devoid of a woman in with sexual function during pregnancy is not justifiable when the pregnancy is out of any danger. So now come a problem why there is so much myth about it. Because people are thinking that pregnancy and childbirth is a disease, but it is not disease. The couple should not deny it of having the sexual pleasure and happiness. The sexual relationship is a part of quality of the life. The women and the couple, we have a plenty of questions regarding the sexual activity during the pregnancy. They will sigh and hesitate to discuss the issue. The doctor also think it is not an issue to be discussed. And moreover, we, the gynecologists, are always in a confused in mind whether should we advise it or should not advise it. Now, there is a lot of knowledge gap because changes in the sexuality can be significant during the pregnancy and in a postpartum period. Unless you are familiar with the scientific data, the potential for providing the patients with misleading and incorrect correct information is really high. The patient may rely on anticots or old wives' tales or other incorrect sources or Google Auntie and WhatsApp University, and this make the life of a couple even more miserable. When the women conceive and welcome a new bundle of joy, the whole family is prepared to welcome the new member. The women start getting many advices, right? Diet, like sleep, like rest, travel, but not about the sexual relationship. So there is a self-imposed abstinence. By avoiding the sex during the pregnancy and postpartum, there is almost 2 years. So it can lead to disturbed interpersonal relationship or extramarital affair of a husband. So approximately 50% of the women surveyed were concerned that intercourse could harm their pregnancy. 91% of the pregnant women made the cutoff for the sexual dysfunction in the female sexual function index compared to 69% of a non gravid female counterpart. So what does this mean? That means the sexual dysfunction is more among the pregnant women because of self-imposed abstinence. Now, the sexual behavior depend upon the many things: the age, the culture, the relationship, the physical changes, the discomfort, the fear of fetal get damage, and the partner sexual function. So now coming, what's the pregnancy has a effect on the sexual dysfunction. We know that progesterone is increased in the pregnancy, so it is responsible for the physical and mental changes. Estrogen can affect the sexual desire and the function. Oxytocin released during the orgasm can cause the uterine contraction, and prolactin, it increase when it is label is increased, especially during lactation, can cause and affect the sexual desire. So this is the effect of the sexuality by effect of the pregnancy and childbirth, after childbirth to the pregnancy. Now, what is the effect of the pregnancy in the sexual function? Now, there is a lot of psychological changes. Like there is a decreased self-esteem, there is anxiety, there is fear, there is body image dysfunction, the perceiveness of loss of attractiveness because there is an increase in the gain weight. There is a lot of chloisma, everything in the faces. So there is a cultural differences. There is a myth about the sexual practice. There is an interpersonal relationship. These all have a psychological effect. The physical aspect of sexuality in pregnancy, there is the nausea, the vomiting, the urinary frequency, the urgency, back pain, fetal movements. Many times it's very disturbing. The breast changes, the genital changes, the vaginal secretions, the abnormal girth, which cause the discomfort and can have a bearing on the sexual activity. Now, these are the effect of the pregnancy on sexuality. Now, because of the taboo attached to the sex, many couples do not consult the doctor because they think, is sex during the pregnancy is safe? When it is not safe, can sex harm the baby? Can intercourse orgasm lead to abortion or uterine contraction? Is sex derived increase or decrease during the pregnancy? And what is the men's view? So why there is a decrease in sexual activity? Because in pregnancy, physiologically, there is a fatigue, there is a dyspareunia, there is a decreased libido, there is a breast tenderness, there is a fear of injury to the fetus, there is genital vasoconstriction, the negative body image, the physical discomfort, the urinary frequency and urgency, the postpartum, it causes dyspareunia, the episiotomy pain, the fatigue, the milk leakage, the nipple tenderness, or the sexual role is changed. So these are factors which actually decreases the sexual activity and desire in the pregnancy and postpartum. So now coming what's actually the truth and what we are thinking the myths around the sexuality in the pregnancy, what is the truth? So be aware of the sexuality concern during the pregnancy to answer the queries of the couple. Most pregnant women can engage in the sexual activity throughout the pregnancy, provided there is absence of any complication. The sexual desire, the libido, the arousal, orgasm may vary during the third, all the three trimesters. Couples should keep some label of intimacy during throughout the pregnancy. This helps them to keep the relationship healthy. So the sex during pregnancy is a very low risk behavior, except when it is associated with the high risk pregnancies or there is a bad obstetrical histories. Now, what is the advantage of having sex? Many people are coming and they are asking, we are very much comfortable of not having sex during the pregnancy because I think there is no advantage of having sex in the pregnancy, but it's not true. There is a lot of psychological usefulness. There's a many data indicate that overall sexual satisfaction can correlate with the feeling of the happiness during the pregnancy and more attractive during the late pregnancy. So there is a psychological bonding between the couple. The induction of the labor, because they are the natural prostaglandins which are there in the seminal fluid, can favor the maturation process of the cervix, and it become more flexible, allowing easily dilatation and effacement of the cervix. So actually it help in the induction of the labor. The preeclampsia prevention, many studies shows that the partner semen when the prostaglandins is there, it actually help in when it's observed, it has some severe immunomodulators, and it help in prevention of the preeclampsia. So will sex be different during the pregnancy? Yes, it might be, because the desire is actually different in all the three trimester. So it is definitely different during the pregnancy. Sex feeling is sometimes more pleasurable, sometimes less pleasurable. Increased blood flow to the pelvic area can cause engorgement of the genitalia that may uncomfortable feeling of the fullness. So at in that time, the females are not feeling to have a sexual intercourse. The heightening sensation that result may add to the pleasure during the sex. More vaginal discharge or moistureness may also help in having the sexual intercourse. The mild abdominal cramp due to the uterine contraction after orgasm can happen, but overall there is no reporting of the preterm labor pain. The breast may feel tender and unusual sensation to touch, particularly in the first trimester. The breast remain more sensitive throughout. Some women may prefer to have their breast not to be touched. So, what is the reassurance that will it harm the baby? So, baby doesn't get harmed having the sexual intercourse, because there is it will protected by the amniotic fluid. So any thirst which is given during the sexual intercourse, that it go into the amniotic fluid and it not go into the fetus. So the baby is not harmed. The thick mucus plug which is there, it seal the cervix and help in guarding against the infection. While orgasm may cause mild contraction, but I stated before also, they are temporary and harmless. With orgasm, baby may move around more. This is because of increase in the heartbeat of the mother and the uterine contraction, but it will subside after some time, and we have to assure the patient that it is absolutely harmless. So now question arises, when it should be avoided? At any of the high-risk pregnancies, if there is a toxemia in the pregnancy, there's a diabetes, there's a anemia, there's a multiple pregnancy, there's a bleeding per vagina, there's a abdominal pain, premature uterine contraction, or there is a leaking per vagina, low-lying placenta, the previous bad obstetrical history, or there is a recurrent abortion, the previous history of the cervical incompetency, or when the partner having the genital herpes and other STDs, then it should be avoided. So Is it is normal to not having sex during the pregnancy? Yes, it is normal. Pregnancy hormones can reduce libido, so it is quite normal to don't have sex in the pregnancy. Now, what is the parents to be have? Means the husband behavior. Men can feel more attracted as usually during the first and the some second trimester. He may feel less interested in third trimester due to increase in the abdominal girth. The reason for the lack of desire because there is a fear that the baby may hurt, or they worry about the wife and unborn baby, apprehensive about the burden of parenthood, and self-consciousness about making love in presence of unborn child. It is due to the culturally affected the sexual desire. So doctors should discuss about the fear and concern with the dog to be the husband should be reassured and advised that it is absolutely safe in pregnancy to have a sexual intercourse if the pregnancy is devoid of any complications, which I have already discussed. So is the oral sex during the pregnancy is safe? Yes, absolutely safe. But avoiding the blowing of the air into the vagina is actually is not safe because there are few reports that is called the air embolism and can be fatal. So it is safe if he kisses or stick and licking the coitus and labia rather than inside the vagina. Now the coming to the positions. The sexual positions which are more comfortable during the pregnancy should be asked to them. Like, there is nothing known as a particular, it's like not like a mathematics or rule. What the couple actually feel to have easy when they are comfortable, which position they are comfortable. It is between the two couples in which position they are comfortable. So we have to advise, and every person is different, every couple is different, so we should ask them, guide them, and let them decide it that which position is good for them. As the pregnancy process, the missionary position is not comfortable anymore. Overall, the course of pregnancy, the use of men on the top position decline and women on the top side by side or near the entry point are practiced more often. So these are the different positions, and I already stated what is the comfortable. They have to choose that. In any position, the pressure on the abdomen and deep penetration inside the vagina should be avoided. So, on a large meta-analysis showed that more than 98% of the pregnant women preferred genital to genital contact with other type of sexual activity may being desirous is low. With a little experimenting, each couple should work together, finding the technique they are suitable. The communication and openness are the key to maintain or improve the sexual satisfaction during the pregnancy. So there are the various sexual dysfunction during the pregnancy. In female, there is might be low lack of libido or anorgasm or dyspareunia. In male, yes, low libido, premature ejaculation, and erectile
Excuse me, sir,
dysfunction.
last 2
So
minutes.
yeah, sure. So the complications, it might be theoretically, yes, preterm labor, but in large study, it doesn't so have any cause of preterm labor. Prematurity can happen, but again, it's need really a very large study to advise that prematurity can be caused by the sex during the pregnancy. Fetal distress, there is a no overall association between the sexual activity and the fetal distress. Antepartum hemorrhage, despite a limited evidence, it is probably safest to advise patient with the placenta previa to abstinence from the sexual activity to reduce the theoretical risks of catastrophic APH. Vaginal bleeding, yes, we should avoid. It might cause PID, yes. Study found if there is a frequent intercourse and there may be PID, so it always advisable to use the barrier that is condom during the having sexual intercourse during the pregnancy. Venous air embolism, I already stated, it is during the oral sex. If there is a blowing of over the vagina, it can causes and cases are reported. So last 2 minutes, wait till the bleeding stop completely and wound have healed. Normal involution of the genital tract has occurred. One is physically and emotionally ready to have sex, and use of the contraceptive is mandatory in the postpartum cases. So most society advised to start sexual intercourse 6 to 8 weeks after the delivery, either normal, cesarean, or instrumental. If one is not yet ready to have a sex intercourse, then continue foreplay by being physically close to each other can be advisable. So lack of the sexual desire after delivery, feeling exhausted, maybe lack of sleep, demand of motherhood, high prolactin level, low estrogen, feeling of low in the postpartum depression, and post-cesarean is likely recovering from a major operation. So advice to the patient, just I want to conclude, give accurate information and dispel the myths what they have in the mind. Discuss about the sexual matter, about uh, open with the couple, so that if they are comfortable, if the pregnancy is free of any complications, they can practice this. Counseling can relieve the couple's anxiety and enhance adjustment to their changing relationship, which may help prevent the development of the long-term conflict. So for any inquiry or problem regarding the sex intercourse, ask your doctor. So thank you so much.
Thank you. Thank you. So, Dr. Savannah, ma'am, please your expert comments.
Excellent presentation, Dr. Apurva. You have covered almost everything, but just to add two lines, take home messages. All the beneficial effects of the sexual activity implies during pregnancy also. Also, some of the beneficial effects which I want to add is the increase in the oxytocin level, decrease in the blood pressure. Also, there are so many studies which is say that increased sexual activities decreases the listing of preeclampsia also. And also one of the most important thing is the bonding between husband and a wife. So this one, but again, Apurva, what you said, one word, self-imposed abstinence. There is also family-imposed abstinence. There is some culture in Indian culture where this one pregnant lady has to go to the mother's place from 5 to 6 months of pregnancy. There is a family-imposed abstinence. So overall, I should say that sex and the sexuality of the woman has to be encouraged throughout the pregnancy until unless there is some specific conditions like bad obstetric history, cervical incontinence, or low-lying placenta, etc. Thank you so much. Excellent presentation, Dr. Apurva.
Thank you so much, Savannah ma'am. Thank you so much, sir.
Thank you. So let's start on our session 2. It is a panel discussion, MTP POXO Act legalities simplified. Case-based discussion. For this to moderate, I would like to welcome our Dr. Richa Sharma ma'am, Chairperson MTP Committee Foxy, and Dr. Kiran Chandna ma'am. She's a President Faridabad Foxy and member of MTP Committee Foxy. And thereby they can introduce our panelists. Thank you.
Okay, thank you, Dr. Sharma. So, okay, can you allow me to share my screen?
Now you can.
Yeah.
Yeah.
Okay, so once again, a very good evening, everybody. So now we are going to have the panel discussion on MTP and POXO Act legalities, case-based discussion. And I welcome my panelists, and I request my panelists to introduce themselves with, okay, Dr. Renu Chawla, can you introduce yourself?
Yes, I'm Dr. Renu Chawla from practicing in East Delhi in Kailash Deepak Hospital. I'm a graduate and postgraduate from Lady Hardinge Medical College.
Okay, welcome, Dr. Renu. Dr. Pratibha Agarwal, please introduce.
Good evening, everyone. I am Dr. Pratibha Agarwal. I'm working in Jipmar Hospital, Pondicherry. I am a DGO DNB, and and working in Jipmar Hospital.
Okay, welcome, Dr. Pratima. And I request Dr. Alka Kuthe to please introduce yourself.
Hi, good evening all. Myself Dr. Alka Kuthe. I am consultant gynecologist and medical legal advisor. I am national coordinator of Foxy Ethics and Medical Legal Committee, and I would like to help anybody who is in medical legal crisis. Thank you.
Okay, we welcome you, Dr. Alka. And Dr. Maushmi Ghosh, please introduce yourself. Are you there, Dr. Maushmi?
He was there, I think.
Okay, she has not joined. Okay. So, Dr. Siyoga Pant,
Yes,
kindly introduce yourself.
yes. Good evening to all of you. I am Dr. Suyoga Panak, consultant obstetrician and gynecologist practicing in Amravati since 15 years. And I have a special interest in the field of medical legal aspects. I have served the government college, government institute for almost 12 years. And now I am doing private practice.
Okay, welcome. Okay,
Thank you,
Dr. Kanchan Mala, please introduce yourself. Has she joined?
Yes, ma'am. Good evening.
Yeah.
Myself, Dr. Kanchan Mala Gupta, obstetrician and gynecologist working in Kanpur as private practitioner.
Okay, we welcome you, Dr. Kanchan. So
Yes,
with
ma'am.
this
Thank you.
introduction,
Dr. Richa, Dr. Mosmi
and my
is there.
co-moderator is Dr. Kiran Chandna. She is the president, Faridabad Obs and Gynae Society. So now before we begin our brainstorming discussion, we all know that MTP is governed by the Act. Okay, and it was enacted in 1971 and then it has undergone amendment. The recent amendment is 2021. So this amendment actually has further empowered the women and it expands the access to safe and legal abortion services so as to ensure the universal access to comprehensive abortion care. And this journey actually MTP Act, it clearly tells us. See, MTP, we all know, we have been doing right from our PG time. The procedure is very simple. Either we do the suction evacuation or we do any other surgical abortion or medical method. It is so simple. But there are the medico-legal issues which are related to MTP that is very important. So this act clearly tells us who should do the MTP, the provider's eligibility, then indication also, then place, and most important is the paperwork. So they have clearly formulated and given the guidelines. So now this amendment journey, it was not a small journey. You can see the step ladder. It has gone through various phases. First, it was approved by the cabinet 2020, then it went to Lok Sabha, then passed from Lok Sabha, then went to Rajya Sabha, passed from this, then published in the Gazette in March 2021, implemented in September 2021, and finally the notification came out on 12th October 2021. So now we are with the new MTP Act amendments. So now my first question is to Dr. Pratima. Now, who is RMP? What do you mean by RMP? We always say RMP can do the MTP. So what do you mean by RMP? And who are the doctors who are eligible to do the MTP? In another word, what is the provider's eligibility?
Ma'am, RMP is a recognized medical practitioner who is a registered in state medical register and who has degree, PG degree or diploma, and after MBBS, 6 months of house surgency or at least 1 year of experience in OBGY in government approved hospital. And after amendment of MTP Act, now up to 20 weeks, 1 RMP is needed. Opinion is needed, and after between 20 to 24 weeks, 2 RMP opinion is needed. After 24 weeks, 1 medical board opinion is needed. And here 1 medical abortion up to 9 weeks, only 3 months experience in OBGY in any hospital or in 10 cases cases of medical abortion under the supervision of the RMP in government established hospital or government approved hospital is needed. And and up to 12 weeks, who is done assisted 25 MTP or 5 in which 5 is independently done in the same government approved hospital or government established hospital. And yes.
Okay, so now after amendment, now this has actually strengthened our peripheral doctors, the MBBS doctors also, as we can see. So when up to 9 weeks, MBBS doctor who has 3 months of experience, or they have given a medical method of abortion to 10 cases under the supervision, so they can also prescribe the medical method of abortion. Now, when we are talking about the opinion, see, less than 20 weeks, 1 RMP opinion. So, but we have to understand this very clearly. Suppose any patient comes and she wants MTP, say about 10 weeks, you are planning to do the suction evacuation or medical method. So in that case, you have to get the opinion of RMP who is eligible for that period of gestation. So the MBBS doctor who is eligible to give a medical method up to 9 weeks cannot give the opinion for doing the MTP after 9 weeks. Okay, and similarly, the MBBS doctor who can give the who can do the MTP, you can clearly see the purple column. So they can give the opinion till up to 12 weeks only. And PG degree or a diploma holder and the MBBS having 6 months of house surgency or 1 year of experience in obs and gynae, so they are treated as equally as the PG degree or a diploma holder. So they can do MTP at any period of gestation as per the law. So I think I'm very clear with this. So whenever we say registered medical practitioner, registered means 2 qualifications should be there. Means their degree or a diploma or a MBBS, it has to be recognized as defined by Indian Medical Council. And the name is also entered in the state medical register. So this means they are registered one. Now, Dr. Kiran, will you take second question?
Yes, ma'am. Thank you, Dr. Richa, madam. So I would like to ask, what are the indications for MTP? Can we do the MTP for contraception failure at any gestation age? Or can the unmarried woman undergo MTP after 24 weeks? Or any need of any document, if there is any need of any document to prove that it is a contraception failure?
To Dr. Renu.
Yes, as we know that medical termination of pregnancy amendment rules are there, which were launched in 2021. So according to that, up to 20 weeks, the indications are to save the life of the mother, to prevent grave physical or maternal injury to the mother, and if there is risk of physical or mental congenital abnormalities in the fetus, on humanitarian grounds, like as if the pregnancy has occurred because of rape, and if there is contraception failure, whether the woman is married or unmarried, but if contraception failure is there, they are eligible to undergo MTP. So if we have to do the MTPs for the category of 20 to 24 weeks, then the indications are if she is a survivor of sexual assault or rape or incest, if she is a minor, if there is change of marital status during the ongoing pregnancy, like if she has become widowed or the divorce has occurred, then if the woman is with physical disabilities means if she has a major disability as per criteria laid down under the Rights of Persons with Disabilities Act, which was launched in 2016. So if the other indications are if she is a mentally ill woman, including mental retardation, if there is fetal malformation that has substantially risk of being incompatible with life, or if the child will be suffering from major disabilities, then this becomes an indication for termination of pregnancy. If the woman with pregnancy in humanitarian settings or disaster or emergency situations as declared by the government, and if she is beyond 24 weeks of pregnancy, then it is majorly done for fetal malformations.
And one thing is that the unmarried women are also included under clause 7. So they are also entitled for MTP between 20 to 24 weeks. And contraception failure is not there. So we can do MTP for contraception failure only up to 20 weeks. Now, Dr. Renu, what about the document? Do we need the proof that it is a contraception failure?
No, we don't.
Yeah. So we don't need only the if patient says, we take it for granted. There is no proof required as such for that. So then other question is to Dr. Moshmi, if she is there now, or anyone can take it. Now, which are the places? You are there. Okay. So
Dr.
now
Moshmi
tell,
here. Good evening.
welcome, Dr. Moshmi. So now tell me, can we do the MTP at any place, at any clinic which is not registered, or the place has to be registered, private or public?
Yeah, definitely the MTP center has to be registered. Without the center being registered, we cannot go for MTP, or it has to be a government institute established by the government or run by the government.
Okay, what about the clinics? Can we prescribe a gynecologist? Can they give MTP?
We need authorization for that. The center should be recognized. Only then we can go ahead.
Okay, so up to 9 weeks, a clinic which is not registered, also they can do the MTP by medical method of abortion, provided they have the linkage to the other center which is registered. For that, they have to display the undertaking also in the center. So this is one point which we have to keep in mind. And government hospital, they don't have to take any kind of approval. By default, they are approved. It is only for the private setup who have to take the approval. Okay, so Dr. Kiran, will you take the rapid fires?
So what are the minimal investigation you will advise for MTP? And can you prescribe MTP medical method of abortion on telemedicine without any visit?
Whenever we are asking minimum investigation, we are asking for low risk patient.
Low risk.
So we can I take this?
Yes.
Can I do?
Yeah,
Hello.
Yeah. So minimum investigations required are blood group of the patient should be known, blood group and RH typing, and hemoglobin, urine routine microscopic examination, and blood sugars. And if we feel that there are some complications, if she has some medical problems, then accordingly the other tests should be done.
And most frequent asked question is that whether you want to do the ultrasound or not.
If clinically you are sure that it is intrauterine pregnancy and the period of gestation, what she is telling about the amenorrhea is corresponding, then we do not need to do ultrasound before giving the medical method of abortion.
Yeah, so it is not mandatory. Yeah, but it is desirable. See, but what I feel, Dr. Renu, if the cases we have like the previous cesarean, okay, such patients, or if the patient is presenting early in the gestation, we can really not pick up the ectopic pregnancy. So nowadays, I think ultrasound is so easily available. So I would definitely do the ultrasound before I do MTP, so as to save myself from the medico-legal implications. Dr. Alka, you are raising your hand, please.
Yeah, same I was going to say. So era now to save ourselves from medico-legal case.
Exactly.
So better to go for ultrasound. It is not mandatory as per that. That's what you have said.
Yes. Okay, so what about prescribing on telemedicine?
Usually
yes,
it
Dr.
is not
Suyoga.
advisable.
Yeah.
Yes. Basically prescribing medical MTP pills on telemedicine or without giving any visit, it is not advisable, because unless we examine the patient and rule out all the medical complications or any other obstetric complications, we should not give. And more than that, the patient should fill the C form also, the consent form. So without that, I don't think we should advise any prescription like that.
Yeah, so that is the most valid point. This was actually for the COVID era, pandemic, when we were doing the telemedicine. But still, one visit is very mandatory, as you rightly said. The consent form has to be signed, and examination also, if you want to do. Okay.
So what should be the valid? Yes, ma'am.
Yeah. Yeah, take it. Dr. Kiran, you can go ahead.
Okay. What should be the valid consent for MTP? Is it the woman herself or patient attendant or in case of if the patient is major and if the patient is minor, but what should be the consent like of patient?
Dr. Kanchan, are you there? Yeah.
Yes, ma'am. I'm here.
Yes, ma'am.
If the woman is adult, the consent of woman is sufficient, and husband or partner consent is not needed. And now, because of amendment, the partner is also included, because so many relations are there. So many persons, couple are living in live-in relationship. And the Form C is very important because it is unique, where only the consent of women is required. In the case of minor or mentally unsound, the legal guardian or the parent is needed if the patient is less than 18 years. So legal guardian or the consent of the parent is needed here.
Yes. And the legal guardian can be any person. Need
Yes,
not be the
any-
blood related person. He can be
Yeah.
anyone. He or she can be anyone.
It may be
So-
authorized by the court also. And there are forms which are very important for record for filling as well as for record information in the following form, like consent form, that is Form C, very important form, both for medical as well as surgical abortions. And number 2 is there are RMP opinion form, less than 20 weeks period of gestation, that is Form 1. And Form E is for RMP opinion between 20 to 24 4 weeks of period of gestation. And for the medical board, where the period of gestation is more than 24 weeks, it is Form D. Form 2 is required for monthly reporting form, which is to be sent to the district authorities. And Form 3 is admission register for case records.
Okay, so these are the 4 basic forms which we have to fill for MTP. Now we have to remember one thing, either we are doing it by tablets, okay, by mifepristone or misoprostol, medical method, or we are doing by surgical technique, or we are doing in early trimester, first trimester, second, or even now third trimester. Any trimester, we have to fill these 4 forms. It is mandatory. Now, this is the consent form. These are just the format consent form. So we all know now we have discussed already the consent of patient is only sufficient. This is the format of the Form 1, that is for MTP till 20 weeks. And this is Form E. This was a new form which was introduced. Now, suppose if you forget what is the indication which we have to fill Form 1 or Form E. So if you see these forms now, they also clearly mention the indication, because you have to tick whichever is most applicable. So here, and now it is also written here is that we always have to write the MTP number. MTP number means
very important.
this form, that is a serial number, is very important. And this serial, because these are the only document where patient's name will be written, but rest of the documents patient name should not be written at all. So this serial number will come from the admission register, which is a register 3, which we will be showing. This is a format of Form D for the medical board. Now this is the Form 2 monthly reporting form. You have to send all the previous data, last 1 month data, to the district authorities within first week of every month. And these are the new changes. And I assume everybody has got this form, because it is quite a lot of time since the amendment. Now Form 3, this is actually the register. And the serial number comes from this register, because this register you have to change every year. And this you have to assign a particular serial number to any patient, whoever comes. So here you have to write, there are 16 columns. You have to fill all these 16 columns. And once you assign a particular serial number, then all the documents should have the serial number and not the patient's name, and including the discharge summary also. So this is very important. And all the MTP forms we have to preserve for at least 5 years. These are the medical legal documents. Okay, so quickly we'll go to the other question now. Okay, rapid fire. Dr. Kiran, will you take this?
Yes, yes. Which place the MTP beyond 24 weeks should be done? And how will you dispose the products of conception, placenta, or fetus after MTP? First question, please.
Ideally, Madam Dr. Kanchan, may I speak?
Yes.
Yeah, please.
Ideally, MTP beyond 24 weeks should be done in the hospital established or maintained by government, or to be approved by government or the district level committee conducted by CMO. And for disposal of products of conception and placenta.
Do you want to
using
add
the-
anything, Dr. Alka? Wait, 1 minute, Dr. Kanchan. You want to add something beyond 24 weeks? Which places?
Yeah, it's actually a medical college in that
Yes,
city.
it has to be a tertiary center. Beyond 24 weeks has to be the tertiary center. It is not only the government setup, because we all know government setup can be the peripheral health centers, CSCs can be there, district hospital. So these cases has to be managed with a tertiary care hospital who have all the facilities. Okay, how will you dispose POCs, placenta and fetus?
POC, fetus, placenta, product of consumption, all should be separate in yellow polythene, yellow
biodegradable bag. Yeah.
Bag.
And what about the fully formed fetus?
It may be cremated or buried according to
incinerated or
bury the patient. Hospital or the attendants?
The health performer who is performing the procedure.
Is it? Anybody wants to answer, Dr. Alka? Yes, please.
Yes, actually, this is very private matter, MTP and the fetus. So we should never give fetus in the hands of patient's relative. It is the responsibility of the hospital and the doctor who performs MTP.
Yes.
Otherwise, what can happen? You have seen in the past female fetus lying here and there, and again many assaults and cases on that because of female fetus was found in that sewage, that area, or all that. So it is the responsibility of the hospital and of course the MTP doer ultimately that he should see the fetus is disposed properly in that yellow colored bag, and as per the biomedical act is there, accordingly we should dispose the products of conception.
Fetus, yeah. So unclaimed fetus, if they are not wanting, it is the hospital responsibility. But ideally, you have to hand over the fetus, okay, to the parents. To the mother, you have to hand over. You have to keep a proper register. You have to get the proper signature for that they have received the fetus, and then you hand over the fetus. POC is not the problem because just the products are there. You can dispose them in the biodegradable yellow bag. Okay, so this is very important. You have to dispose it properly.
One thing I will like to comment regarding consent. Just now the doctor said the consent of only adult woman is required. It's okay as per the MTP Act. But again, as an abundant word of caution, if we ask the lady to bring some relative, any relative, because sometimes what can happen after anesthesia or during anesthesia, if you conduct MTP above 9 weeks, there can be some problems, allergy to the drug as well. Anything can happen with the patient.
Yes, that is fine, Dr. Alka. Other precautions we are taking as we are doing any other case, like any other surgical case or medical case when we are admitting. Yes, we have to have an attendant also. But as far as the signature goes, by law, she is sufficient enough. Yes.
She can.
And other thing, what I was...
Yeah.
Yes.
Ma'am, regarding handing over the fetus to the relatives or to the biomedical person, what we do, usually we ask the relatives whether they want to take the fetus for cremation. If they are willing, then we hand over and give take the signature of the relatives. And if they are not willing, we again take a consent that they are not willing to take the fetus, and then we hand over to the biomedical person.
Yeah, that is fine. And if the fetus, if the period of gestation is more than 20 weeks, we have to fill the stillbirth form. That is important.
Yes.
Okay, so we go to the next. Now, this is a very important question. Now, how we should get the centers approved? What is the procedure for registration, getting your centers approved for MTP? So this is to Dr. Alka.
Yeah, it's a very important question because on this question only the whole MTP Act is there. MTP, as per the provisions of the MTP Act, any MTP is legal if it is performed at the center which is registered by the government. Secondly, as per the indications given in MTP Act and by a person, registered medical practitioner as defined in the MTP Act. So this three important thing, if we follow, then we are not liable for any punishment, even if some adverse event occurs or some mishap occurs. So we must strictly follow this indication. As per the provisions, Form A, that is Section 4 of the MTP Act says that we have to fill the Form A, and there are two categories, MTP below 24 weeks and MTP above 24 weeks. As per the category A and B, there are certain requirement of instruments and some necessities for the patient, like table, general gynec table or some operation table, resuscitation equipment, anesthesia equipment, life-saving equipment, IV fluids. So there are two categories. As per the categories, we have to apply for registration, and the form A is there. We have to fill the form and submit the form properly filled, signed by us to our district level authority. Of course, wherever the health operation corporation is there, health officer. Previously, we used to give it to civil surgeon, but now it's the health officer whom we have to approach to get our center registered. So form A is for form for application as per the section 4 of the MTP Act. And after we fill the form A for approval, this form B, that is the approval given by the district level authority. He can be health officer or civil surgeon depending upon the area of jurisdiction. But this form is very important for registration of center. But as we discussed before, if the practitioner is RMP, even if the center is not recognized, he or she can perform medical methods of abortion, provided he displays on the wall of his hospital OPD area.
Yeah, that we have discussed. They should have the linkage to other hospital. Okay, but what are the necessary documents one doctor should attach with the form A?
Yeah,
when they are applying. Yeah.
As per the requirements of MTP Act, we know the trainings the doctor has to undergo. So suppose it is up to 8 weeks, suppose up to 12 weeks, up to 20 weeks, and 20 to 24 weeks, depending upon gynecology's diploma, 6 months house course, 1 year of house course. Depending upon the requirement of the RMP definition, we have to apply the document, our documents. Again, we have to apply an anesthetist document who comes to our hospital for regular anesthesia, or we can attach 1 or 2 anesthetist document if at all we want, because every time the same anesthetist will not be available for us. But important thing is that our degree and diploma document plus our training document, and apart from these 2-3 things, I think they require the instrument
Dr.
list.
Kiran, you want to add? Dr. Kiran has taken the registration. Do you want to add exactly what papers we should attach?
List of instruments also, depending upon the category of the center we want to recognize. So there is a different list of instruments, category A, category B. So because it is the availability of instruments and all those things that will fulfill our
okay, Dr. Kiran, Kiran, please add.
Yes. We have to apply. We have to apply whether we want the registration up to 12 weeks or we want up to 24 weeks, and depending upon the facilities in our places. We have to show these days. They take the pictures of our things in the hospital that we have got OT table also, or we have got OT light and anesthesia machine. We have taken all the emergency drugs we have there. According to that, we apply on that paper, and we deposit our degree also there, and then we apply on it. Then they come for
the degree is
inspection.
important. See, if you are getting your center registered only till 12 weeks, okay, so registration is given till 12 weeks or till 24 weeks.
24 weeks.
So if you are asking for registration till 24 weeks, you have to show the degree of the 2 gynecologists, because you will need the opinion of 2. So you have to show the degree of those 2, then anesthetist also, then the owner, whoever is the owner of that hospital or nursing home, whatever their registration, okay, their registration certificate also they have to put, they have to give the undertaking. So these are the must forms, apart from other pictures and everything what you are saying, if they at all ask. And you should have the setup also. 1 minute, Dr. Alka. So if you have to have the setup, the only difference between getting your center registered till 12 weeks or till 24 weeks is in the terms of OT setup. So in that case, you should have the OT where you can perform the surgeries, abdominal surgeries or vaginal surgeries. Then anesthetist availability should also be there, and equipment should be there. And plus the transportation facilities, all emergency drugs and everything you have to maintain. And for the audience sake, you can go to the website. There's an elaborated list of all the emergency drugs and everything. You can refer to that. Yes, Dr. Alka.
Yeah, in addition to the attachment of second RMP for pregnancy up to 24 weeks, this is beyond 12 weeks or beyond 20 weeks, because 2 opinion beyond 20 weeks as per the amendment. But in our local situation, there are a list of instruments availability, and we have signed that list. Generally,
Yes,
we
you have
the-
to write whether you fall in the category A. See, if you can see this form I have displayed also, the form A. Whether you are in category A or B, you have to take. Acha, most important message is that before the amendment, I think this point also is clear to everybody. Before amendment, who got the registry approval for 20 weeks automatically means 24 weeks. Okay, so you don't have to reapply for re-registration. But then you get your form B updated. You have to write the application, get your form B updated, because in earlier it will be written up to 20 weeks. So you have to get it corrected to 24 weeks. Why you want to get it corrected? Because you have to display this also in your health facility wherever you are doing the MTP services, and patients should not get confused. So this is a most important thing. Now, question 6 is to Dr. Sujoy. Now, a gynecologist, she performed suction and evacuation for 10 weeks of pregnancy at her friend's clinic. Okay, and that clinic was not registered. So is she justified? Can she do that? And whether she is liable for punishment or owner is liable for punishment? And yeah.
Yes, ma'am. Yeah. Now, looking at the medical, legal, and the consumer cases which a gynecologist are facing nowadays, knowing the MTP law and its implementation is very important. So, any gynecologist who is a qualified person should not perform any suction evacuation or MTP at a place which is not registered, because all the offenses under the MTP Act, they are cognizable, non-bailable, and non-compoundable. So that is most important. And the punishment can range from 2 to 7 years of rigorous imprisonment to the person who is performing, and also if the place is unapproved, even the owner is also responsible for that, or any administrative head who is running the hospital is responsible for the act and may be punished for the same. Only in cases of failure of documentation or record keeping or taking the valid consents, a fine up to 1,000 and or may not be 1 year of imprisonment can be subjected to.
So yes,
the
so
concerned
this
person.
is when the MTP Act is contravened. Okay, the person eligibility or the
Yeah.
place or the indication and also the document. So this is the punishment. We have to be very careful about it. So quickly we go to other POCSO Act.
Dr. Richa, one statement only.
Yes, Dr. Alka. Yes.
This is very private matter, MTP of the person or woman, secret document. Previously, in the old act, it was only just fine. But in the amended act, there is both fine and punishment, means imprisonment. So
Yeah, that we have discussed. That Dr. Sujoy has said. Yeah, it is there. Yeah. 1 year of imprisonment also. Okay. So now quickly we go to the POCSO Act now. Yeah, privacy is very important. So POCSO Act, we all know it is the Protection of Children from Sexual Offense Act. And children means both boys and girls. So it was enacted in 2012. So basically in this case under POCSO Act, we have to understand two lines very clearly. Any minor girl who is less than 18 years, so she just cannot give consent for the sexual intercourse. So whether it is a consensual or it is a forced, it is considered as an offense. So that we have to keep in mind. Even if she is married also and she is minor, it is assumed it is a offense. So this is very important. So all the minor cases with sexual assault, we have to report to the police. I'm not going into this one. There was one Supreme Court order recently, 2022, wherein they have said that if there is a girl who is less than 18 years, so in that case, they need not disclose the identity to the police, need not inform the police under POCSO Act, provided the minor and the guardian give in writing. But this is just a Supreme Court order. But of course, we have to respect Supreme Court order. It is binding for everybody. But then this is just for your information. And I request each and everybody, don't go by this until it has been incorporated in the Act. Okay. So less than 18 years, we have to inform to the police.
We have to inform police. We should not disclose the identity. Yeah.
So we'll come to that. So if we don't inform.
Can we finish in 2 minutes, ma'am? Last 2 minutes.
Okay, quickly. Just 2 minutes are there. I think 10 minutes are still there. Okay, so we have to inform. If we don't inform, that means 6 months of imprisonment. Now, quickly, I will go to the important cases in that case. Okay. So, Dr. Kiran, will you take this question?
Yes, yes. Can the female be punished for sexual assault under POCSO? Can we withdraw the allegation of sexual assault in the POCSO Act? Or is it the right of victim under POCSO Act to get the legal assistance if the patient is not able to afford it?
Dr. Alka, this is to Dr. Alka.
Yeah, it's a non-compoundable offense. We cannot compromise. If the offense is there, it has to be non-bailable, cognizable, and non-compoundable. It is the right of the victim to get legal assessment if she or he not able to afford. And again, if it is with a trust, everyone is informed with trust and honesty, then not liable for punishment anybody. If it is some mean intent or some crooked mind, then only the child of whoever is there can be punished.
Yes. And just one thing I want to add, whenever you get any POCSO Act, okay, so you have to contact to the Child Welfare Committee, the nearest CWC, and they really help those victims, and they also help in giving the legal aid, advocates also, and they help in all the proceedings free of cost. So whenever you get such cases, contact CWC of your area. That is very important. So now quickly, okay, so whenever any sexual assault case comes to you and they have not lodged the complaint to the police and they have just come directly brought by the mother or the relative to you. So as a gynecologist or a practitioner, how will you proceed? Will you call the police first and then, or what is your method? Dr. Moshmi, are you there? Yeah.
Yes, yes, definitely. But with that,
you are not audible. Anybody else can take quickly. We are running short of time.
Whether we are in public sector or private sector, it is our duty to give first aid to the patient. So whatever bruises or cuts or wounds they are there, they need to be taken care of. And it is doctor's duty to inform the police whether they want to do the case or not. But police should be informed. But first aid should not be denied to the person whosoever has come. First aid should be given.